Greeting from actually Boston this time. I'm here for the annual conference of the ELSO. The news from annual ELSO conference is that in a few hours from now, the 6th edition of the Red Book would be out. So a new edition of Red Book is now being unveiled. Anyway, let's leave alone the gup-shup here and focus on what I would deliver. I thank Pranay and Venkat once again for inviting me to give this talk. Also, congratulations on getting your course accredited by ELSO. Now, my talk today is on how you set up an ECMO service. An important talk in many contexts because these are things which are not often discussed much. And there are a lot of non-technical skills and soft skills that come into the fore when you set up an ECMO service. At the very outset, except from being an ECMO enthusiast, I have no conflicts of interest to declare. Now, to start off with, one of the common things I get to hear from my colleagues and friends whenever they set up an ECMO service is a story something like this. We have 2 machines that we bought during the pandemic. We tried it on a couple of patients. Both of them or a few of them died. We're not confident about using these machines. So we've cleaned the machines up and cleverly locked them up in our store, not knowing what to do next. And this has been a recurring theme for a lot of new institutions that wanted to start ECMO during the pandemic time. The theme was even evident even before the pandemic. A lot of centers went through the roughs and toughs of setting up an ECMO service. And I believe you go through these ups and downs initially, mainly because of a lack of strategized approach to setting up the service. Setting up an ECMO service requires essentially, you need to plan. You need planning and development, followed by implementation and sustenance. Eventually, you need to evaluate how your service is and plan for the future. Most of us, so when you look at it actually, the point where you start buying your machines is somewhere in the implementation and sustenance phase. So we rather skip the planning and development phase, which clearly impacts on how the rest of the course of your ECMO service runs. So, yeah, so this is something, which people keep to have in the back of their mind when they are setting up an ECMO service. And when I say that it needs that much of dedication and planning, the average timeline from the time you plan an ECMO service in your hospital to the time when you first have your patient on ECMO will be somewhere around 12 to 18 months if you were to follow this course diligently, because it essentially starts off with commitment from your management, the hospital management, and then you select your champions, you train them, you eventually make sure that while you train them, you train others too and develop some set protocols for management of ECMO patients in your unit. And that's when you start looking at buying your machines, and eventually you go on ECMO for your first patient or you initiate ECMO thereafter. Clearly, we do skip a lot of these steps, and that's where we run into troubles. A lot of ECMO programs that sprouted during the pandemic are currently not functional at all for the same reasons, because things were done in a hurry. Now, let me talk about institutional commitment here. There are a few aspects of institutional commitment that comes to the fore when planning an ECMO service. Of course, you need to plan your key personnel. You need a leader, both from the physician side and the surgical side, who would lead the program. You would also need other consultative services. The most important bit when you talk to your hospital management about commitment would be the conversation on return of investment. I'm sure, when you're working on the private side, which is not funded, say, centrally or by the state government, as in the public side, a lot of this will boil down to the economics. which is essentially the economics of ECMO. Convincing a hospital management on return of investment might be difficult. You need to understand that an ECMO service, when it's full-fledged, it takes about 3 to 4 years before you start to get clear return of investment. Having said that, if you were to talk to your CEO about setting up the service, you need to make sure you compare other services offered by the hospital appropriately. You would find that, or it has been found that, ECMO services are less expensive than setting up an organ transplant service or a cancer chemotherapy service, for that matter. So essentially, you need to make sure that you convince the hospital authorities properly, and you would even find that the number of or the cost of ECMO, say for a 20-year-old patient with myocarditis who spends 5 days on ECMO, might be far less than a septic patient who would spend more than a month on ECMO and end up having renal failure or chronic renal failure. So, these are things that would need to be compared appropriately when you hold this conversation. And of course, the economics of ECMO has also been looked at in various trials. I'm not going into the details of it because these things change in context and would depend upon the resources where you set up the ECMO. So the point here I'm trying to make here is institutional commitment is big, and it needs to be streamlined properly. Then comes the formation of your team. Of course, you need a ECMO director, a nursing lead. I would rather say the core pillars of setting up a team would be the director and his team of champions. A nursing champion, a perfusion champion, a surgical champion, as well as the allied staff who needs to be involved. Clearly, the point and we are trying to get into the team is a shared mental model. And by this, what I mean is every person in the team should be able to understand what exactly is happening to the patient as well as to the machine. It should not be like, your ECMO circuit or your ECMO pump fails and you wait for your perfusionist to arrive and sort it out. So people should be aware of what problems are being discussed about your ECMO patient. And that's where, and that will eventually contribute to clearly good patient safety. And that's where training your team becomes very important. You need to make sure that you have a standardized, accredited training program for your ECMO ECMO program as such. And essentially, you would need to reflect on how the patient's outcomes are as part of this entire process. Not just that, you also have to make sure that you inculcate a culture of safety in the unit, and your protocols should underline this very clearly. In addition, so we spoke about some of the key personnel in the team. When you manage an ECMO patient, clearly, we spoke about the fact that they should be all on the same page when you treat the patient. So in addition to these key personnel, you would also need to make sure that you identify your customer right. As I know, initiating an ECMO program or starting a new ECMO center, you may want to think about how you want to run it. You may want to run an ECMO program that just caters to, say, only respiratory failure, or you may want to run an ECMO program that exclusively caters only to cardiac failure. A lot of institutions do both respiratory and cardiorespiratory failure, so they initiate ECMO in patients with cardiopulmonary failure. But then, as and when you develop your program, you would soon come across situations where, you will have to start thinking about adding in other services, say ECPR, or having some basic facets of management. However, when the patient needs advanced management, the patient needs to be shifted to a nearby tertiary institution. So it essentially, these are things that needs to be planned well ahead as you set up your ECMO program. So if we are talking about a respiratory ECMO program, for example, you need to understand that there is no point having too many hospitals running ECMO machines within the same vicinity. You need to make sure that you cover a catchment area of at least 2 to 3 million population when you're going to offer an ECMO service in your hospital. That would roughly work down to a minimum of 12 cases annually, and you need at least 12 to 20 patients annually to maintain your skills, at least for your staff to maintain skills or bedside skills while managing ECMO patients. So we'll talk about skills and training soon, but these are the rough numbers you're looking at when you're setting up an ECMO service. Staffing wise, of course, this was historically manned by professionists, but as the subspecialty, I would say, evolved, we figured out that there is clearly a resource crunch when it comes to the number of professionists. So a lot of nursing staff and physicians started getting trained to the point that, team as such, as I said earlier, when they get trained together. So these components of the, the team, which I was telling you earlier, would have all these members. Clearly, you need to, as part of your protocol making, you need to make sure that you have an idea of how many patients to nurses, what would be your patient to nurse ratio in patients receiving ECMO. Most of the centers or new centers would start off with 1:2. When I say 1:2, say one patient and two nurses. And as you gain experience, you would move to a 1:1 model or even 1:2 model. But then these are things that are not done from the word go. These are things that are done as you gain experience. The most important part of the ECMO team is the fact that they should be self-sufficient, and the fact that you need non-intensive care unit support services too when you run your ECMO program. The most important bit is a working blood bank. Running an ECMO program without a blood bank facility in your hospital would be a disaster. Now, as much as training of staff goes, and this is an important part of setting up your program, you need to make sure that you don't just attend conferences or other you read up materials pertaining to ECMO. You also need your proficiency to be evaluated and your understanding to be assessed. So it becomes important that the training program for your staff in your hospital is holistic. It covers both theoretical and practical aspects of ECMO support. Most institutions run at least an ECMO workshop for their in-house candidates at least once a year. And during that process, they make accreditation of their staff based on certain norms. So that's something which you may want to incorporate into your setting up schedule. And centers that do smaller volumes, you may have to figure out how your staff members go through a retraining process or undertake say simulation-based training like how it's offered in this course to maintain their proficiency. As I said earlier, all ECMO specialists, irrespective of what background you're from, should be adept in managing ECMO emergencies. There should be role clarity within the team, and this needs to be spelled out in the protocol as to what each person's role is when it comes to daily management. So you essentially will end up having a lot of templates for each of the team to highlight as part of your routine ECMO rounds. But that's more for the patient safety side. And as I said earlier, credentialing your ECMO team members, at least institutionally, is going to be important even from a medical legal point of view tomorrow. As and when you develop your protocol, you will realize that there are materials available online, such as the ELSO guidelines, as well as individual center guidelines. However, you would want to choose what would suit your background, your resources, and make a center-specific policy while you develop your protocol. When we talk about equipment, you have a lot of equipments in the market, and each one has its own pros and cons. So it's best that the ECMO director sits down with his lead perfusionist, deciding which machine you would want to buy. Mind you, it's good to stick to one machine so that training becomes easier. Most of the centers buy at maximum of 2 machines at a time, so that even if there is shortage of supplies, they can sustain their ECMO program. But having all ECMO machines available in the market and keeping them in your hospital will have logistic issues when it comes to training, since each of these machines have their nuances of management when it comes to running it. The other thing I want to highlight is the fact that as and when you set up your ECMO program, sooner or later you will be referred patients from peripheral hospitals. So you'll soon start looking at a transport, setting up a transport service. Again, do that diligently. Have an activation workflow whereby everybody in the team knows about a potential ECMO patient, and adequate logistics are arranged when patients are referred and transported on ECMO. More importantly, it's important that you educate your peripheral centers about when to refer. Now, criteria for referral will be different from criteria for initiating ECMO. Your threshold for referral should be somewhat lower than your criteria for initiation. So you need to educate your peripheral hospitals on the appropriate criteria at which they should refer your patients. We in Singapore essentially ask, say, patients with ARDS to be referred from the time they are prone positioned. And once they are referred to me, essentially it's my headache to figure out how the patient progresses. And I follow up till the patient either gets better or needs ECMO. So the decision on going on ECMO is on me, but I clearly know that there's a potential patient waiting who would need ECMO at some point. And it's not just me, the entire team knows about it. So yeah, I mean, that's something which comes as a part and parcel of ECMO, setting up an ECMO setup. Program evaluation for quality assurance needs to be done. Review of major complications should be held, and frank talks on morbidity and mortality should be encouraged. More importantly, ECMO centers should look at submitting their ECMO data to international databases such as the ELSO registry. The advantage essentially here is that not only would you be able to know your overall progress, you would be able to compare your progress with what is happening globally. This also gives you an international summary of how things are around the world when it comes to VA, VV, and ECPR kind of ECMOs. Of late, a lot of new programs embark on an advisory committee consisting of, say, experts from outside the institution to assist with their program development. Now, this makes it easier because a lot of these experts would be from ELSO accredited centers or centers that report to ELSO otherwise. So they clearly, make sure that the program comes up in a good way and the protocols are streamlined appropriately. And it's not just that. Having a rapport with a bigger center also helps you bail out some of your patients who would not be able to be managed in your center too. There are guidelines. Of course, there are position papers for VV ECMO setting up and VA ECMO setup. Of course, the ELSO guidelines have been recently updated, and you get them all online on the ASAIO journal. So a lot of these guidelines should help you with your protocol development as and when you start your ECMO services. So the short and sweet of what I was talking so far, program implementation is not or is full of ups and downs. It's a kind of emotional roller coaster Mind you, this doesn't apply to just setting up an ECMO service. It can be any other service in the hospital. You all start off with optimism, excitement when you have your first patient on ECMO, the thrill and euphoria when the patient comes off ECMO, and then you go into a phase of denial, fear, and desperation when your patient dies on ECMO. Eventually, you become despondent, depressed. But that's what sets the tone for the rest of your ECMO service or continuing your ECMO service. Essentially, you come up with innovative ideas to beat what has happened so far, and you make adjustments, and that's where you improve in your services. So you have a point of maximum risk as well as a point of maximum opportunity, and I think both of them have their important places when you set up an ECMO unit. So yeah, I think I will stop here, and I'm more than happy to take your questions if there are any. Thank you.